Okay, today I will be presenting about the drug Denosumab, better known by its brand name as we just saw in the commercial, Prolia. Denosumab, or Prolia, is a treatment for postmenopausal osteoporosis, and it works by increasing bone mass density to help strengthen bones. In this presentation, you'll learn more about how Denosumab works exactly, but first let's understand the disease, osteoporosis. As many of you may remember learning in fall and winter quarter of this aging class, osteoporosis is a systemic skeletal disease characterized by low bone mass density, BMD. There are no obvious symptoms of osteoporosis, and on its own, it's not harmful, but it does increase the risk of fractures. As we can see in the image on the left here, we have normal, healthy bone. It's honeycomb-like in structure and sponge-like. In comparison, on the right, we have diseased osteoporotic bone. It's much more porous. You can see all these holes here. There's less bone, and the bone is thinner. So as you can imagine, it's a lot easier for it to snap and break. Osteoporosis increases its prevalence with age exponentially, as you can see in this graph for both men and women across the world. It is higher in prevalence in women. If we look carefully on the y-axis here, for men, it goes up to 5,000. For women, we're looking up to 8,000. So throughout all these ages, it's a lot higher in women, which is why Prolia or Denosumab is targeted toward postmenopausal older women. Before we go further into osteoporosis and Denosumab, we need to understand how bones work. Bones are a dynamic tissue. This means that they're constantly being broken down and reformed. This works by osteoclast cells binding to the bone and resorbing it, so it almost looks like there's a hole here. Then the osteoblast cells come in and they remineralize the bone, and the bone is strengthened. As you can imagine, there needs to be a healthy balance between osteoclasts and osteoblasts to maintain a good bone mass density and healthy bone overall. Osteoporosis can occur when there's an imbalance and there's too many osteoclasts compared to the number of osteoblasts. This means that way too much bone is being resorbed compared to the amount that is being formed. So these osteoclast cells are formed when this cytokine RANK ligand, RANK-L, binds to this receptor activator known as RANK on the precursor. When it binds, it's basically telling the precursor to go ahead and make more osteoclasts. Additionally, in the body, there is osteoprotegerin, and this acts as a competitive inhibitor. It binds to RANK-L, just like RANK does. But when it binds, it forms an inactive complex. So RANK-L cannot bind to RANK, which in turn limits the number of osteoclasts. So it's super important that we have OPG to help balance and make sure that there's not too many osteoclasts being formed. There is a problem, however, when menopause occurs. Menopause leads to a decrease in estrogen levels. As we can see in the graph here, they're pretty high pre-menopause, then there's a sharp decline, and they stabilize at a low value. Estrogen stimulates OPG production, and as we just said, OPG helps to limit bone resorption. So when there's less estrogen, RANK-L can bind to RANK more frequently, and there's more osteoclasts and more bone resorption. This is where the drug Denosumab comes in. Quick recap, RANK-L binds to RANK to form the osteoclast. OPG also binds to RANK-L, but as a competitive inhibitor to limit the osteoclast production. In menopause, we lose the number of OPG that we have, so we need something to substitute OPG's role, where we have Denosumab. Denosumab binds to RANK-L just like OPG did, This is good because it helps limit the number of osteoclasts being formed. This rank L can no longer bind to the rank. This makes sense in theory, but let's look at its evidence of effectiveness in practice. In this first case study here, we can see the bone mass density percent change measured in postmenopausal osteoporotic patients in the lumbar spine and total hip. Those who received the denosumab injection had a positive increase in bone mass density in both of these areas, and those on the placebo actually had a decrease in their bone mass density. In an extension study, all of these patients were given denosumab, and all of them had an increase in BMD. This is good as it's showing denosumab is actually strengthening the bone. Another case study compared the incidence rate of new vertebral fractures. Here we have all 3 years of the case study combined, and it's also broken up by every month. And we can see that those receiving the placebo had a much higher incidence of fractures compared to those with the denosumab injection. Again, this is because denosumab limited the number of osteoclasts, so the bone was strengthened and it was less likely to break. In conclusion, osteoporosis is the most prevalent disease in postmenopausal women because of the decreased estrogen production. Denosumab essentially substitutes estrogen's role as a competitive inhibitor for osteoclast formation, and it ensures that bone resorption and bone formation are in balance, which helps strengthen the bone and reduce the risk of fractures. Thank you so much for your time and attention, and if you have any feedback or questions, I'd love to hear. Thank you.